Hi everybody, my name is New Doan and today I'll be presenting on peripheral artery disease or PAD. At the end of this lecture, you should be able to list risk factors for peripheral artery disease, recognize common signs and symptoms for PAD, be able to classify a patient with PAD when given an ankle brachial index value, distinguish treatment options that provide cardiovascular benefits versus treatment options that improve functional capacity. Finally, you'll be able to develop a treatment and monitoring plan for patients with asymptomatic and symptomatic PAD, as well as plan for patients after revascularization procedure. These last two objectives will be the focus of the in-class activities. Last week, you guys focused on coronary heart disease, where the cause of the disease state resulted mainly from atherosclerosis of the vessels in the heart. This week, we will be focusing on the vessels outside of the heart, mainly the lower extremities. Peripheral artery disease is the narrowing or blockage of arteries, reducing the flow of oxygen-rich blood to the body. Common causes for these blockages is atherosclerosis, which is a buildup plaque made up of fat and cholesterol deposits that tend to harden over time. Specifically, the term peripheral artery refers to those arterial vessels in the periphery, like in your head, your extremities, as well as your other organs. These include extracranial carotids, renal arteries, mesenteric arteries, and arteries in the upper as well as lower extremities. This lecture, we will be focusing on the lower extremity peripheral artery disease, since these arteries are the most commonly involved arteries. PAD affects 200 million people worldwide and 8.5 million in the US. The risk factors for PAD are similar to those of the atherosclerotic vascular diseases. According to the American Heart Association, AHA, and the American College of Cardiology, ACC, the risk factor for PAD can be broken up roughly into three categories: age, known atherosclerotic disease elsewhere, and having risk factors for atherosclerosis. Risk factors for atherosclerosis include diabetes, history of smoking, hyperlipidemia, hypertension, and obesity. Smoking and diabetes have particularly strong associations with PAD, and smoking represents the single most important modifiable risk factor for PAD. As laid out on the slide, these atherosclerosis risk factors play an important role in defining the risk factors for PAD in patients less than the age of 65. The signs and symptoms of PAD are variable. The common signs and symptoms of PAD are listed on this slide, with the least severe at the bottom and most severe at the top of the pyramid. The vast majority of your patients will present asymptomatic or with atypical leg pain. So most of your patients will be at the bottom two sections of the pyramid. In clinical studies, atypical leg pain has been defined as non-joint related limb symptoms that can contribute to functional impairment, such as impaired walking, which is comparable to patients with claudication. The classic symptoms associated with claudication include fatigue, discomfort, cramping, or pain in the muscles of the lower extremities like your thighs or your calves. These symptoms is consistently induced by exercise and relieved by rest, so usually within 10 minutes. The key thing to remember about claudication is that the symptoms are reproducible and are relieved in a set amount of time. Although claudication is the hallmark symptom for PAD, it only occurs in maybe 10% of the patients with PAD. Lastly, approximately 1% of your patients will present with signs and symptoms in the most severe category, which is limb ischemia. Limb ischemia can be broken down into the acute and the critical limb ischemia. The acute phase results from severe hypoperfusion of the limb, typically occurring in less than 2 weeks, which is characterized by pain, pulselessness, cold, and paralysis of the limb. It can further be classified as viable, where the limb is not immediately threatened. And then there's threatened, where there is mild to moderate sensory or motor loss. And there's also irreversible, where there is major tissue loss or permanent nerve damage. On the other hand, critical limb ischemia is defined by chronic ischemic rest pain for 2 weeks or longer, non-healing wound or ulcers, or gangrene in one or both legs. So within this definition for critical limb ischemia, there are a couple of definitions that you need to know also. Ischemic rest pain is classically described as a burning sensation in the ball of the foot that becomes most bothersome at night due to the loss of perfusion through gravity when lying flat. A wound is considered to be non-healing if it persists for greater than 2 weeks despite conservative therapy. So those are the two definitions within the definition of critical limb ischemia. Patient who has one of the previous risk factors should undergo physical examination. On physical examination, findings include diminished pulses, vascular bruits, and non-healing wounds or gangrene. So bruits are abnormal sounds generated by turbulent flow of blood in an artery due to an area of partial obstruction, and this can be from atherosclerosis. The likelihood of PAD confirmation is increased if a patient has multiple abnormalities that are found on physical exam. Unfortunately, physical examination alone has relatively poor sensitivity. Therefore, in order to accurately diagnose PAD, other conditions that possesses similar signs and symptoms must be considered and excluded. Other conditions that may look like PAD on a physical exam include peripheral neuropathy, arthritis, deep vein thrombosis or DVT, venous congestions, injury, infections, or malignancy. The signs and symptoms of physical examination findings of PAD can be confirmed by measuring the ankle brachial index, or the ABI. ABI is a simple, non-invasive test that has been proven to be highly sensitive and specific in diagnosing PAD. To measure the ABI, the patient lies in a supine position with cups placed just above the ankles, avoiding lower extremity wounds if possible. After the patient is well rested for 5 to 10 minutes, the systolic blood pressure is then measured at the brachial arteries on both arms and the dorsalis pedis and posterior tibial arteries of the legs by using a Doppler probe. The ABI of each leg is then calculated by dividing the highest pressure obtained at the dorsalis pedis or posterior tibial arteries by the highest pressure taken at the brachial arteries. Based on the AHA-ACC guidelines, values for normal and abnormal ABI are listed on the slide above. It is important to remember that each leg must be interpreted separately. However, when evaluating patients' cardiovascular risk, the lowest ABI between each leg is used. So you will want to aim for the number that is the lowest between the two legs when you are evaluating the patients for cardiovascular risk. So depending on the clinical presentation and the resting ABI values, additional physiologic testing studies may be indicated. If the ABI is greater than 1.40, this typically signifies the presence of arterial calcification. in which the calcified vessel is so calcified that it cannot be compressed. In this case, the toe brachial index, or the TBI, is needed to help diagnose PAD, as the vessels in the toes are often spared from calcification. Value for TBI interpretations are different from ABI. A normal TBI value is greater than 0.70, where a value less than or equal to 0.70 confirm peripheral artery disease. An exercise treadmill ABI test is helpful in diagnosing PAD in symptomatic patients with normal or borderline ABI values. Patients with PAD will demonstrate a significant drop in ABI after exercise, but their pain will be normal or unchanged. PAD diagnosis can be confirmed 3 different ways in summary. If your ABI is less than or equal to 0.9, if your TBI is less than or equal to 0.7, or if you have an abnormal exercise ABI. So these patients who are diagnosed with PAD would also warrant treatment. Previous studies have demonstrated that patients with PAD are less likely to receive appropriate treatment than patients with other forms of cardiovascular disease. However, patients affected by atherosclerosis at any site are at an increased risk for fatal and non-fatal cardiovascular events. A low ABI has been found to be an independent predictor of future cardiovascular events. In particular, patients have a 2 to 4-fold relative risk increase for cardiovascular events and all-cause mortality compared to patients with a normal ABI. Over the span of 5 years, most patients with PAD remain stable. However, 10% to 20% have worsening claudication, and 1 to 2% develop critical limb ischemia. Critical limb ischemia confers a poor prognosis. At 6 months, as many as 40% of patients with critical limb ischemia will undergo amputation of the affected limb, and approximately 20% of the patients will die within the first year of presentation. When given treatments to patients for anything, it is important to know our goals for therapy. Currently, the main goals for therapy in patients with PAD are to reduce risk of cardiovascular events and mortality, reduce symptoms of claudication, and improving overall quality of life, as well as preventing complications. When assessing a patient with PAD, functional status is greatly related to a patient's quality of life. So functional status is the patient's ability to perform normal daily activities required to meet basic needs, fulfill usual roles, and maintain health and well-being. All of the activity of daily living and instrumental activities of daily living are components of functional status and are listed in this slide. Before we jump into prevention and treatment options, let's quickly review the pathogenesis of atherosclerosis to get a better understanding of how the pharmacologic therapies we have to treat PAD work. Atherosclerosis is the result of injury to the endothelial cells of an artery, resulting in formation of a fibrous plaque through the accumulations of lipids, immune cells, and connective tissue elements at that site. In order to help prevent the formation of a clot in this area that may already be compromised by plaque formation, antiplatelet agents and anticoagulants have been studied. The diagram in this slide represents the coagulation cascade on the left side and then the platelet activation on the right side. This slide is only for your information. However, it is a great way to visually capture where some of the agents work. The antiplatelets agents we will be covering in this lecture includes aspirin, clopidogrel, ticagrelor, and vorapaxar. The anticoagulant will be covered is going to be warfarin. Primary prevention is the use of an intervention to prevent events prior to any clinically manifested disease. In the case of PAD, it typically refers to the role of therapy in preventing an initial cardiovascular event in patients with asymptomatic PAD. In general, literature supporting the screening of patients who are asymptomatic with an ABI is limited. The U.S. Preventative Services Task Force does not recommend routine screening with ABI because of a lack of evidence that early detection results in more effective treatment of risk factors or better outcomes. Guidelines recommending screening typically examine patient risk factors for PAD before recommending the ABI. Specifically, in patients at increased risk of PAD, but without history or physical examination findings, measurement of ABI may be considered. However, patients without risk factors for PAD and without history or physical examination findings suggestive of PAD, an ABI is not recommended. Upon obtaining an ABI, asymptomatic patients with an ABI value of less than or equal to 0.90 may be considered for aspirin therapy at dose of 75 milligrams to 100 milligrams daily. Lastly, there is substantial evidence that smoking cessation reduces cardiovascular events and mortality in peripheral artery disease. Passive smoking should be assessed and prevented. Medical therapy for PAD should address both treatment to prevent major adverse cardiovascular events and treatments to improve functional status, such as claudication symptoms and prevention of critical limb ischemia and amputation. As we discuss the treatment options, please try your best to complete this slide regarding those medications that have been shown to reduce cardiovascular risk and those have been shown to improve functional status. We will revisit this slide during the in-class activities. Non-pharmacologic therapy through a structured exercise program is a key component of improving functional status in patients with PAD. Structured, in this case, means that the exercise is planned, tailored for each patient, and occurs through a supervised exercise program. This program can take place in a hospital, an outpatient facility, and in the community or at patient's home. No matter the setting, the exercise is under guidance of an educated healthcare providers. Studies have found that supervised exercise programs are more beneficial than unsupervised exercise programs. The exercise involves intermittent periods of walking until the patient reaches moderate to maximum claudication symptoms, followed by periods of rest. Patients must undergo this exercise for a minimum of 30 to 45 minutes per session, at least 3 hours a week for a minimum of 12 weeks to see benefits shown from the studies. These benefits mainly focus on symptom management, such as improved walking distance with less discomfort and quality of life. There have not been any studies showing improved ABI, and evidence on whether these programs reduce cardiovascular events and mortalities is still unclear. The main limitations to structured exercise programs are the lack of availability of these programs and the lack of reimbursement for the patients. Although home-based walking exercise is not as effective as supervised exercise, it is a useful alternative with some positive effects on quality of life and functional walking status. Alternative modes of exercise such as cycling, strength training, and upper arm ergometry may be useful alternatives when walking exercise is not an option for the patient. We are now going to move on to talking about what pharmacists know best, the pharmacologic treatment options for PAD, starting with antiplatelet therapy. Antiplatelet therapy is recommended for all patients with symptomatic PAD. Agents include aspirin, clopidogrel, ticagrelor, and vorapaxar. The main benefit of antiplatelet therapy, with the exception of vorapaxar, is the reduction of cardiovascular risk. So aspirin, clopidogrel, and ticagrelor have the reduction of cardiovascular risk, and vorapaxar does not. Monotherapy with antiplatelet agents have been found to be beneficial and is therefore recommended. On the other hand, dual antiplatelet therapy is typically not recommended for PAD. There are some situations that may justify the use of dual antiplatelet therapy, which we will discuss later in this lecture. So aspirin works by irreversibly inhibiting the prostaglandin cyclooxygenase in platelets, or the COX, and hence prevents platelet aggregation. The most recent AHA-ACC guidelines recommend a dose of 75 to 325 milligrams of aspirin daily. However, the CHEST guidelines recommend a dose of 75 to 100 milligrams daily. In general, larger doses of aspirin have not been shown to be more efficacious than lower doses in reducing cardiovascular risk and may increase the risk of GI bleeding. Interestingly, although aspirin has been a mainstay of drug therapy among patients with PAD, as well as being considered high-level recommendations in the guidelines, the data supporting aspirin use in patients with PAD has been mainly extrapolated from studies with coronary artery disease patients, meta-analysis of retrospective controlled trials of aspirin versus placebo in patients with PAD, or taken from post-hoc analysis limited to patients with symptomatic PAD. Clopidogrel and ticagrelor are P2Y12 inhibitors that work through inhibiting adenosine diphosphate, ADP. ADP activates adhesion and aggregation by binding P2Y1 and P2Y12 receptors. The difference between clopidogrel and ticagrelor is their type of binding. The binding that clopidogrel has is irreversible in comparison to ticagrelor binding, which is reversible. Clopidogrel at the dose of 75 milligrams daily has been shown to be more efficacious than aspirin at reducing cardiovascular risk. However, although the study found a statistically significant difference, some may not consider a difference of 1.2% favoring the clopidogrel group to be clinically significant. Current guidelines do not make a preference for either aspirin or clopidogrel. As with aspirin, side effects include non-major bleeding, and contraindications include active pathological bleeding, such as peptic ulcer disease or intracranial hemorrhage. Ticagrelor is dosed twice daily at 90 milligrams per dose. A comparison study of ticagrelor and clopidogrel in symptomatic PAD to reduce cardiovascular risk has been published. The study did not find any difference between the two agents in terms of cardiovascular risk reduction or major bleeding. In addition to bleeding, as a common side effect of ticagrelor, studies also found an increase in dyspnea. As with clopidogrel, contraindications to use include active pathological bleeding. Unlike clopidogrel, ticagrelor has an additional contraindication of history of intracranial hemorrhage. Finally, patients receiving ticagrelor discontinue treatment more often than those receiving clopidogrel, mainly because of dyspnea and minor bleeding. The last antiplatelet agent we will be discussing is vorapaxar. Vorapaxar works by reversibly inhibiting protease-activated receptor 1 to inhibit platelet activation and aggregation. The medication was studied in addition to standard antiplatelet therapy with aspirin, clopidogrel, or dual antiplatelet therapy. Although studies have not found benefits in terms of cardiovascular risk reduction, a subgroup analysis of patients with PAD found benefits through the reduction of hospitalization and revascularization. However, This was at the expense of a moderately increased risk of bleeding. Additionally, the number of patients with symptomatic PAD in the study was small. Hence, the guidelines state that overall clinical benefit of Vorapaxar added to existing antiplatelet therapy in patients with symptomatic PAD is uncertain. Anticoagulation should not be used to reduce cardiovascular risk in patients with PAD. Studies have not found a benefit and have shown increased harm through increased risk of moderate and severe bleeding. This lack of benefit may be explained by the pathophysiology of atherosclerosis, unlike venous clots, which are composed primarily of red blood cells and fibrin. Arterial clots contain higher concentrations of platelets and few red blood cells. In the past year, a few studies have been published on direct oral anticoagulants' effects on PAD. A subgroup analysis of the Aristotle trial evaluated the association of PAD with clinical outcomes of stroke, systemic embolism, and bleeding with warfarin and apixaban in AFib patients with or without a PAD. As can be seen, there was a significantly lower number of patients with PAD compared to no PAD. The outcomes prior to adjustment show a decreased number of strokes and systemic embolisms in PAD group. However, after adjusting for patients' characteristics, there was no difference in cardiovascular events. Similarly, COMPASS PAD evaluated the efficacy of aspirin, rivaroxaban, and dual therapy on cardiovascular outcomes of MI, stroke, and death from any cause, as well as limb-threatening ischemia and amputation. The study found that dual therapy lowered major adverse cardiovascular or limb events by 31%. Rivaroxaban versus aspirin alone did not reduce cardiovascular events but did reduce adverse limb events. Currently, these agents are not recommended, but with more clinical trials, maybe one day have a place in PAD therapy. So Xarelto, however, was recently approved with a new strain, 2.5 milligrams from the COMPASS study. So per studies, it must be used with aspirin, so it cannot be used by itself. And currently, Xarelto is the only agent that has an FDA approval for use to reduce cardiovascular events in patients with CAD and PAD. So it's the only anti-10A anticoagulations out there that with this indication. Statin therapy is recommended for all patients with PAD. Statin use has been associated with a 17% decrease in cardiovascular events. Even in the most advanced cases, statin use is associated with a lower one-year rate of both mortality and cardiovascular events. Furthermore, statin use is associated with a reduction in adverse limb outcomes, including amputation, and studies have found that statins improve pain-free walking distance. It is recommended that patients with PAD receive high-intensity statin, and it is recommended for all patients with PAD. Cilostazol is different than the agents we previously talked about, in the sense that it does not have cardiovascular benefits and is mainly used to treat claudication and improve functional status. To be more specific, cilostazol improves walking distance and quality of life. Cilostazol is a type 3 phosphodiesterase inhibitor that works to suppress platelet aggregation. Additionally, it has direct arterial vasodilating effects. Cilostazol is typically dosed 100 milligrams twice daily, but may need to be reduced to 50 milligrams twice daily when given with CYP2C19 inhibitors or CYP3A4 inhibitors. The medication should be taken on an empty stomach, so 30 minutes before or 2 hours after breakfast or dinner, due to absorption effects impacted by the presence of food. One of the biggest limitations with cilostazol treatment is its side effects profile, including headaches and diarrhea. It is important to counsel patients that these side effects are typically transient, lasting generally 1 to 2 weeks. In regards to tachycardia, the mean increase in heart rate found in study ranged from 4 to 7 beats per minute, which may or may not be clinically significant. Cilostazol has a black box warning stating that the medication is contraindicated in patients with heart failure of any severity. This is due to theoretical concerns related to its mechanism of action and classification as a phosphodiesterase 3 inhibitors or PDE3 inhibitor, as the use of other PDE3 inhibitors have been associated with increased morbidity and mortality in patients with severe congestive heart failure. It is important to assess whether or not a patient has heart failure prior to starting therapy or periodically while patient is on cilostazol, especially if the patient experiences a myocardial infarction. As I stated previously, cilostazol used in PAD is for treating claudication. However, it is unknown whether or not cilostazol has the same benefits for patients presenting atypically or asymptomatically. Another agent that has been studied for treating claudication is pentoxifylline. Cilostazol has been found to be significantly better than pentoxifylline for increasing walking. Pentoxifylline is no longer recommended. Patients requiring treatment with cilostazol will most likely be simultaneously receiving other antiplatelet therapy. Studies have found that cilostazol can be safely added to aspirin or clopidogrel without additional risk of bleeding. Additionally, counseling points should be added to emphasize to patients include the importance of continuing therapy despite perceived lack of benefits when initially starting. Studies have shown that symptomatic improvement may take up to 4 months to see maximum benefit. If the medication is discontinued, benefits generally dissipate after 1 month of discontinuation. Therefore, the medication should generally be used continuously. With a growing number of patients being diagnosed with PAD, there is an increasing recognition that more intensive care of patients with PAD may reduce the need for amputation. Surgical revascularization is currently a second-line option for patients with persisting symptoms. Despite being on effective treatment therapy and in a structured exercise program, revascularization has been shown to help improve functional status, but it does have its disadvantages, such as a high 30-day readmission rate. Technique used for revascularization is selected based on the location of the lesion, length of the lesion, degree of calcification, and operator experience. Revascularization procedures can be quite extensive and can last 3 to 4 hours. Revascularization procedures include several options. Balloon angioplasty involves placing a removable balloon at the problem site and inflating it to stretch the artery. Stent placement involves the placement of a wire mesh tube at the lesion site and expanding it to keep the artery open. An atherectomy is a procedure that breaks up the blockage using a small instrument with a revolving blade. Bypass surgery replaces a diseased vessel with a vein from another part of the body or with a synthetic graft. An endarterectomy is a surgical procedure to remove the plaque material in the lining of the artery. Selection and duration of antithrombotic therapy following revascularization is controversial. Indefinite use of aspirin is standard of care. Dual antiplatelet therapy is not recommended by the guidelines. However, in clinical practice, most patients will also be on concomitant clopidogrel for at least 4 weeks minimum if they underwent angioplasty, atherectomy, or a stent placement. This practice is extrapolated from randomized trials for antiplatelet therapy in patients undergoing percutaneous coronary intervention, or PCI. It is unknown whether this extrapolation is accurate, as the anatomy and the size of the peripheral vessels are not the same as those of the coronary arteries. Pharmacotherapy for a patient with PAD should be customized to address risk factors to reduce cardiovascular risk. These risk factors include diabetes, hypertension, and smoking. Studies have found that the use of angiotensin-converting enzyme inhibitors or angiotensin receptor blockers, so your ACEs and your ARBs, have a beneficial effect beyond decreasing blood pressure. These classes of medications can be effective in reducing the risk of cardiovascular ischemic events in patients with PAD. Furthermore, a health diet, whether carb control or DASH diet, and an annual flu vaccine should be stressed and recommended to all patients with PAD. So smoking is a modifiable risk factor for ASCVD, and this put patient at an increased risk for developing PAD by endothelial damage, arterial smooth muscle proliferation, and inflammation. PAD can occur 10 years earlier in smokers versus non-smokers, and smokers are at an increased rates of amputation and angioplasty. You should advise your patient to quit at every encounter, along with recommendations for nicotine replacement therapy or psychological counseling. Thank you for listening to the pre-class lecture. I hope you are now able to list the risk factors for PAD, recognize common signs and symptoms for PAD, and classify patients using the ABI. Know that you have been introduced to the different treatment options. We will focus more on the difference of these treatment options and recommending treatment interventions during in-class activity. I will see you guys soon.